So I'm going to go through quickly, and I will preface this. It's kind of either ironic or funny that I feel like more of a Luddite and I'm kind of kicking this thing off. So me without my stone tablet and passenger pigeon. We'll try to talk about a few projects we've done in my kind of past life and working with the Department of Veterans Affairs, and really in the space of electronic health record data and health services research. So, these are just some of the overarching objectives for today that I'm hoping to impart to you all in about 10 minutes. But I'll start off by saying it may or may not surprise a lot of people in this room that LGBT populations, from the data that we do have, experience in a vast array of social, behavioral, and health outcome disparities. So that includes smoking, chronic stress, assault, depression. My own work is really focused in suicide, morbidity, and mortality. And at least for the morbidity part, we do know that ideation and attempt are off the charts for LGBT populations. We know a lot less about mortality, and I'll get into that a little bit later. But the key thing here, and why I think some of the stuff we were able to do in the VA is important, but really limited, is that healthcare systems do have a lot of direct services that can get at either preventing or ameliorating a lot of these disparities that we see in this population. But the problem is we have little to no data to figure out if the population most at need, and in this case, LGBTQ plus populations, are actually able to utilize those services within a healthcare system setting, because we really don't have great data on this population within healthcare settings. So for an example here, you can see about almost 1,400 healthcare program grantees of HRSA were required to start collecting sexual orientation and gender identity, or SOGI, data in 2016. And you can see here that the issue is, even if they started to say, like, well, we do collect it, we have a field here, a lot of this information is just simply missing in systems. So you have sort of a, places coming online, trying to get this information or building fields within their electronic structure for it, but then nothing being populated within them. And then you can see here in the second example, a kind of a deeper dive into 12 community health centers looking at their completion rates for SOGI data, that there's a you could drive a truck through that, about how wide that interval is between folks who seem to be missing all of it and some healthcare centers that are doing particularly well at getting maybe most of it for folks. So what do we do in the face of not having this information? So researchers have had to get creative with structured data and unstructured data. So in the EHR space, for those who may not work with EHR data, structured data, talking more about like ICD, or International Classification of Disease codes, diagnostic codes, and then unstructured data would be sort of the written clinical text notes or clinical progress notes. And in the VA, without having information about self-identified gender identity to try to identify transgender and gender diverse veterans, we've had to rely on ICD codes for gender identity disorder. I'll talk about in the end why that's super problematic. But we tried to figure out how well does this code actually get at this population. And this is a study we did back in 2016, 2017. And this is not NLP and it's not machine learning. I kind of categorize it as a glorified word search. So we tried to look into text notes to see, could we find some transgender or gender diverse kind of related phrases in clinical notes for folks? And what we were able to find, you could see here about 7,500 veterans had an ICD code related to GID, or gender identity disorder. And a fair amount of them had really explicit mentions in their records that would sort of corroborate that code, right? So then the second thing you'd want to do is figure out, well, if you don't have that code, are these words coming up for folks? And they did, but very, very thankfully, pretty infrequently. And so we did a hand review. We found that there were 11 folks in this sample of 22,000 that didn't have a code, that their words and phrases were very clearly like the ones we saw for the other group. But then a lot of the false positives in this group were really people talking about some other person in their life, and that happened to make it into the clinical record. So that's sort of the gymnastics we had to do to get gender identity data. We did something similar trying to find sexual orientation data. So looking at sexual minority status. And this was a little bit more sophisticated. I did not lead this study, so I can't speak to the actual NLP that was put into this. But you can see here that finding these folks for this group, the diagnosis codes were not great at all. And actually, most folks who were found through clinical progress notes. Very few of them had both. So it really got into the clinical notes where we found text data kind of to sort of think about, is someone mentioning, someone who was assigned female sex at birth and mentioning her wife or his husband. So what can we do when we find this information on this group? And so again, my research in suicide prevention, we don't have leading cause of death information for LGBT people in this country or anywhere in the world, because we don't collect sexual orientation and gender identity at the time of death for anybody. So we can't look at what is the leading cause of death like we do for different racial and ethnic minority groups. We can't do that for LGBT people. But within this kind of captured population in the VA, you can see here that the line running down the middle, the diagonal, is the top 10 causes of death in the country generally. And then you have what we found for, presumably cisgender veterans and transgender veterans here. And you can see here at the end, suicide is usually the 10th leading cause of death. And for transgender veterans, it was the 4th leading cause of death. And for LGBT veterans, we found a very similar thing. Rather than suicide being the 10th leading cause of death, like the general US population or their kind of heterosexual or non-LGBT veteran counterparts, it was the 5th leading cause of death for this group. Now, there are a lot of problems with this information. One is that ICD codes pathologize sexual and gender identities. There's also huge limitations in terms of misclassification. And lack of documentation doesn't mean someone is automatically cisgender or heterosexual. It's a huge assumption to make. And we really wrestle with how to qualify the folks sort of in that group that didn't have what we were looking for. And then lastly, sort of where these codes are occurring. So treating the code itself as the observation. You can see here in this graph that for the LGBT project, most of the documentation occurred in a mental health setting, right? And so that leads to this, suggestion of informed presence bias, where if you're engaged in mental health care, if you're coming into a system more often, you just have more opportunities for phenomena to be picked up and documented than other folks who don't have as much access or are not utilizing a system as much as you are. And the other thing is that LGBT patients may not want this information in their records at all. But we really need to navigate this lack of data, because without this, there are really huge ramifications for public health and social work science. And we can't really adequately measure burdens of disease or outcomes and risk for this population if we can't find them. It seems almost like a tautology that you have to know something about a person, you have to be able to find them first. We can't measure service utilization. We can't direct resources to subpopulations that are most in need. LGBT research is really a tyranny of small numbers. And when we think about issues of intersectional research, we need a whole lot more numbers to try to find folks who may live at an intersection of sexual and gender minority status, ability status, racial and ethnic minority status. And you need numbers for that. We can't evaluate interventions either. And importantly, we can't hold systems to account. So this gets back to that kind of maxim, no data, no problem. So, I'm not suggesting this is super hard. I think it can be done. It is being done, but it really suffers from this field of dreams effect. That if you build these fields, people will come. Yeah, no, not so much. Missing data is huge. We have to think about the ecology of data collection, especially gatekeepers of information, and the situations in which patients may be disclosing this information, and whether they're environmental things that facilitators or barriers for patients letting us know about the information. And whether adding these measures would create a chilling effect on services. Administrative data are different from research data. Administrative data are usually tied to some sort of deliverable, someone coming in for care, someone coming in for SNAP benefits, someone coming in for supportive housing. So having that identity attached to that outcome, we don't really know sort of how patients and providers feel or think about that in terms of the deliverables that might be tied to that data. And then also, the biggest thing is this renewed culture war against LGBT people from political conservatives. This has real logistical issues in terms of not letting care happen in places, and then also just creating, again, that culture, that environment of fear where people are afraid to come out and disclose information about themselves. So I will wrap up. Thanks. A lot of my collaborators from the VA here.